And I will turn it over to you.
All right, perfect. I took a little shorter than last time, amazingly. Hi, everyone. Thank you very much for having me here today. Thank you, Dr. Varga, and thanks to all of you and the Scleroderma Foundation for hosting this. So I'm one of the cardiologists at Northwestern. I work a lot with my colleague, Dr. Sanjeev Shah, in seeing a lot of patients with scleroderma and heart-related disease. I realize that I am the one that's standing between lunch and you and lunch. So we're going to do our best to get through this, and leave some time for questions. So the other thing I'm going to say is that my talk is probably not as dense as epigenetics and all that. And a lot of the themes that you've heard earlier about fibrosis will come up again. So hopefully this won't be too out there. If you have any questions, though, feel free to please stop me. I want to make sure that everyone understands what I'm talking about. So let's start with this slide. What I like about it is the fact that it shows that myocardial involvement, as shown here, is not typically the first thing that's seen, in patients who have scleroderma. What I don't like about it is the fact that, it suggests that there's this nice order to getting one organ, then the next organ, and then the next organ, and that is not true, right? We know that some people have lung disease and they don't have heart disease, or the other way around. We know that lung disease doesn't have to come right before heart disease. And the other thing is that myocardial involvement, although it is more common in the diffuse cutaneous variant, we see this in the limited as well. So take it with a grain of salt. This figure is from a relatively recent study that shows how important it is to know about the heart when you have scleroderma, because the heart is responsible for a lot of the adverse outcomes in this disease. So patients who have heart-related scleroderma, about 10 to 30% of them are actually symptomatic. They have symptoms that are related to the heart. But a vast majority, 70% and above that, actually have heart-related disease and don't really know it. It's not manifesting itself yet in terms of symptoms. What I mentioned before is that diffuse variant likely to have symptoms and more severe involvement than the limited. And this figure kind of shows that too. This is, the blue represents this U-start cohort that has patients with scleroderma divided up into the red, which is diffuse, and the green, which is limited. So you can see one thing is that even limited has cardiac complications, so it's not just diffuse. But in the diffuse population, about 15% of adverse outcomes in patients with scleroderma are related to the heart. And that's second only to the lung fibrosis you see at the far end of your screen there. So how does scleroderma affect the heart? There are two main ways. One is that it affects it through primary mechanism, a direct myocardial involvement, and I'll discuss what that means in a second. And then the other way is secondarily, through things like pulmonary arterial hypertension, which you heard a lot about from Dr. Kihigas earlier today. Now, many patients have more than one problem. It's not just either direct, primary, or secondary. A lot of patients have pulmonary hypertension in addition to primary disease. So they sort of get it from all sides. This slide, I would say, sums up basically what other talks have mentioned and what it is that causes that direct involvement of the heart. One thing is vasospasm. Vasospasm is when the vessels of the heart, and those are called coronary arteries, it's when they squeeze down, right, and they narrow, and that can block blood flow. So one component of the heart disease is the vasospasm component. And the other component is the inflammation that we've heard a lot about earlier. So I'm going to drill down a little bit. This might be one of the most complicated slides, and it isn't really that complicated. But up here, we have the vasospasm from the coronary arteries. That's the squeezing down of the arteries. And then here we have the inflammation, right? that vasospasm can cause focal ischemia. What does that mean? It means exactly what I said, which is when the arteries squeeze down, they block blood flow, and that can cause ischemia. That's, lack of blood flow is ischemia. And then the inflammation can cause myocarditis, which is just the inflammation of the myocardium, the muscle of the heart. And then all of this can lead to myocardial fibrosis, right? So the fibrosis we've heard extensively from Dr. Hinchcliffe. So this is that scarring, that thickening that occurs in the heart muscle as well, right? And then this fibrosis can do a number of clinical things, right? It can cause heart failure, which is a terrible term, because it's not really that the heart is failing necessarily. It's more about that the heart is not functioning normally. And there are different kinds of heart failure, which I'll explain in a second. But it can cause heart failure. It can cause tachyarrhythmias. So an arrhythmia is an abnormal rhythm of the heart, and tachy just means it's a fast heart rate. So you can get an abnormal rhythm with a fast heart rate. Myocardial fibrosis can also cause conduction system fibrosis. What does that mean? It means that the electrical communication between the top and the bottom part of the heart, because they have to communicate to contract, is disrupted. And it's disrupted because of the fibrosis and the thickening and the scarring. And that can lead to bradyarrhythmias, which is just the opposite of tachyarrhythmias. It's an abnormal rhythm with a low heart rate, because that communication is not working properly. And then down here is a little bit of an aside. This inflammation can actually cause pericardial disease. The pericardium is the sac, the lining around the heart, okay? And if there's pericardial disease, that can cause an effusion, which is fluid around the heart, and that can lead to something called tamponade, which when you have enough fluid around the heart in that pericardial space, it will prevent the heart from expanding properly. And of course, that can cause problems. And then it can also cause inflammation and fibrosis of just the pericardial lining. And if you have a very thick, rigid pericardium, that also can cause the heart, prevent it from expanding. Okay. So I'm going to pick apart then all of these different clinical manifestations one by one. I'm really happy that Dr. Gahigas went before me, because I feel like he did the brunt work of all the, the medical school primer that he gave you guys. So we're going to show pictures again of the heart. This is the left ventricular dysfunction. This is the left ventricle of the heart. The left ventricle of the heart is the part of the heart that is responsible for pumping the blood to the rest of the body. It takes the blood from the lungs that's oxygenated, puts it out to the rest of the body. So if you have dysfunction of the left ventricle, you can get chest pain, shortness of breath, swelling. These symptoms can be what's called heart failure. And heart failure comes in a variety of flavors, but the two main types of heart failure are systolic and diastolic dysfunction. What does that mean? Systolic dysfunction is when the heart pump is not normal. It's not pumping normally. It can't pump all the blood out of the heart. Diastolic dysfunction means that the heart pump is actually normal. The pump is okay, but the heart can't fill normally with blood. And that's typically because with all that fibrosis and scarring in the muscle of the heart, it's, the heart becomes more, instead of a balloon where it's sort of nicely expanding and accommodating all that blood, it's more like a bowling ball. It's very rigid. And so then you can get something like diastolic dysfunction. Usually when you have this, it's an insidious onset. Times when it's acute is when you get acute myocarditis. If you remember back, I said myocarditis is just inflammation of the heart muscle. So sometimes people can present acutely because there's so much inflammation of the heart muscle, they get symptomatic and then present to the hospital. Okay, so that's left ventricular dysfunction. But we gotta talk about the right side too. Dr. Gahigas mentioned this as well. The right side is the part of the heart that collects blood from the rest of the body and puts it into the lungs for oxygenation, okay? And the symptoms that are associated with right ventricular dysfunction are shortness of breath, swelling, stomach fullness, because you get all this congestion, right? And the RV can be dysfunctional because of either primary abnormalities. Again, that's the intrinsic myocardial thickening fibrosis. If it affects the left ventricle, a lot of times it affects the right ventricle. And surprisingly, in many of the studies that are out there, there seems to be some predilection for the right ventricle. That a lot of the fibrosis seems to be more apparent in the right ventricular muscle than the left ventricle. So we see a lot of patients sometimes with left ventricles that are okay, but right ventricles that are not as good. It can also be dysfunctional because of that pulmonary hypertension that Dr. Kahikas was talking about. So maybe not necessarily or in addition to the fibrosis, but maybe because the lungs, the pressure in the lungs is high enough where the blood can't get out of the right ventricle and it starts to become dysfunctional. Okay, pericardial disease. So that's the lining of this blue-purple thing around the heart. Chest pain, shortness of breath, fast heart rate, swelling. So you can get that inflammation around in the pericardium, which is called pericarditis. You can get fluid in the pericardial space, which if you have enough of it can cause tamponade. And you can get what's called constriction, which is when you have all that thickening and fibrosis, not necessarily the fluid, and that also prevents the heart from expanding. Okay. Conduction diseases and arrhythmias. So a lot of patients with scleroderma will tell me that they have palpitations where they feel their heart fluttering, beating really fast, skipping a beat, lightheadedness, dizziness. Some people actually pass out because of these arrhythmias. Extra heartbeats and arrhythmias are very common in patients with scleroderma. And about 2/3 of patients, so a lot of patients with scleroderma have what are called PVCs, which are premature ventricular complexes. These are extra heartbeats, and we can talk a little bit later maybe about what that means, coming from the bottom of the heart. So there's a lot of this going on, and again, it's because of that fibrosis and inflammation in the heart muscle. Okay. And then pulmonary hypertension. Spend a little time on this because Dr. Kahikas talked about it so well, but this is when you have an elevation in the pressure in the lungs, kind of as shown here in this cartoon. So normally very low, but to allow blood to go from the right ventricle through the lungs to the left ventricle. But when the pressure increases, you can start having a lot of right ventricular dysfunction, okay? And about 12 to 30% of patients with scleroderma will have this. All right. So I think you notice, and in pretty much the last 4 or 5 slides, I would mention the symptoms, and they pretty much look all the same, right? Shortness of breath, chest pain. Dr. Kahikas showed that slide, which is like, if someone will come and say, I'm short of breath, is it pulmonary hypertension? Really difficult to know, right? In clinic, we really need other tools to help figure this out. So the first thing that we do in cardiology, or that we think about, is imaging. Because imaging can really give us a really nice idea of what it actually is going on inside the heart. And so we have either the echo, which is this nice old echo machine shown here, and then MRI. And I would actually challenge Dr. Kahikas. He told you that that PFT machine was one of the worst, torture chambers. I don't know if any of you have had a cardiac MRI. It is equally, if not worse, than that. So, and I've been through it, and actually I can't tolerate it. I get claustrophobic. So.
Is it because of the test itself or the claustrophobia?
It's the claustrophobia. So it's a non-invasive test. They don't poke you, they don't prod you. They're probably not even as mean to you as the techs for the pulmonary function test, where they're telling you to blow, 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 blow. But it's lying there in the MRI scanner for a long period of time, and it's being in that tube. I don't want to try to not sell it because I tell everyone to get an MRI, so, but it's not great. Okay. So this is an example of an echo, okay, and just to get you oriented here. So this is a normal looking heart, okay? This is our heart. The echo is sort of showing upside down. So this is actually the bottom of the heart and the top part of the heart, sort of in this, looking up in this direction here, okay? The left ventricle is this structure here, and this is the right ventricle sort of sitting to its side. So blood comes in through the right ventricle, goes through the lungs, and then comes in this way to the left ventricle and gets pumped out of the heart. So normally, you get a nice squeeze of the left ventricle, right? But in dysfunctional LV, that squeeze is diminished, and the left ventricle actually looks big. And you really don't need a medical education background to see the difference between the normal left ventricle and the abnormal. And that is a patient with scleroderma who's got left ventricular dysfunction. Okay, here's an example of an MRI. The heart is kind of turned a little bit around here, but it's the same idea. So here's the left ventricle, here's the right ventricle. This is really normal squeezing for the right and the left ventricle. But here's a patient who's got pulmonary hypertension, and you can see again that the right ventricle is not squeezing very well. The chambers get big. That's how the heart compensates. It gets bigger, and then the function starts to go down. So you're going to see them sort of come together, the largeness and the dysfunction. And it's sort of squeezing the left ventricle. Okay. An MRI can do a really cool thing, which is why I don't want to not sell it here. But MRI can actually look inside the myocardium and look for that scar, that fibrosis that I was talking about. So to orient you again, if I were to take slices this way, like cutting the heart like in a bread loaf, right? Then you're going to end up with these kinds of, this circle with that crescent. Okay, that's how we're viewing the heart. So that this is the left ventricle, the black is the myocardium, the white is the blood in the middle of the left ventricle, and here's the right ventricle here. And these arrows are showing you areas of this white area in the myocardium, the muscle. That's fibrosis, that's scar actually in the myocardium. This one in particular has a lot of scar in the myocardium. And here's an example of myocarditis, which I mentioned earlier. So you can see a lot of patchy white areas in what's supposed to be all black myocardium, and that represents the inflammation and scarring of the heart. Okay? Sometimes you can't actually see the scarring. So a lot of times, especially in scleroderma, we don't actually see what you saw in the last slide. But we know there's a lot of fibrosis in the heart muscle. It's just that it's in between the myocardial fibers. And because we can't see it, here we actually have methods where we can quantify that and see if it's normal or abnormal. Many patients with scleroderma will have a slightly to more than slightly abnormal level of diffuse fibrosis, parts that we can't actually see, so instead of focal fibrosis. And just sort of linking back with the skin score, one of my colleagues, Dan Lee, has done a study where he's correlated this skin score with this diffuse fibrosis marker. And it actually gives a very nice correlation, very strong correlation between how thick the skin is and how fibrosed, how thick the muscle is of the heart. Okay. Remember I mentioned earlier about ischemia, right? Lack of blood flow because of vasospasm, and the vessels of the heart don't work as well. So we can use MRI to perform a stress test. And a stress test is basically allowing us to see what happens to your heart when we stress it, either through exercise or through giving a medication. So in the MRI scanner, we're not really at the point where we're exercising people yet. So we give people a medication. And what I'm going to show you is that this is a patient who at rest, all of this area, I think you can see, it's just fully white. It's like a whiteout, right? And you wait for it, you see that it just gets completely white all the way around. So when we stress the same patient, we gave that chemical, when this contrast comes in, what you're going to see in a second is that there's this black, you see this black area here, this sort of crescent kind of shape. That signifies that in that area, the blood flow is diminished, okay? That there's something causing ischemia or lack of blood flow in that area. And a kind of classic picture for patients with scleroderma is this ring. It doesn't really enhance on this image so well, but this kind of black ring where the arrows are around the white cavity here. That's because it's not necessarily a focal area of ischemia, but actually more diffuse. There's a lack of blood flow all the way in every area of the heart. Okay. Here's an echo again in the short axis. So here's the LV and the RV. This is a patient with pericarditis, inflammation of the lining of the heart. And in echo, a lot of times what we'll see is this funny little bounce between the RV and the LV, and that's because it's constricted. It's not allowed to expand as well as it wants to, so it gives this kind of dance to the septum. It's even clear, I think, on MRI, where you can see the lining of the heart lights up. It's not supposed to be this bright. You're not really supposed to see it at all. So this is a patient with pericarditis, very severe pericarditis, where they have a very thick and scarred down pericardium. And another thing we can do with MRI is we can look at blood flow in the heart. And this is an example of a patient, well, let me orient you here. This is a pulmonary artery. The pulmonary artery, as Dr. Kahikas mentioned too, is the part of the heart that takes the blood from the right ventricle and puts it into the lungs. So this is normal blood flow, so coming out of the pulmonary artery and branching out into the lungs. And this is a patient with pulmonary hypertension. I think you see the difference here. There's a lot of swirling going on. It's not as efficient of blood flow, and that's because there's so much pressure in the lungs. So we can actually visualize flow inside the heart, and this is just the pulmonary artery, to give us an idea of what's going on, all non-invasively. All right. Moving from imaging, we have rhythm monitors. I bet many of you have had to wear one of these devices. These devices allow us to detect arrhythmias or even those extra heartbeats that I mentioned. And they can be continuous monitoring, so they're on all the time and they're constantly measuring, or they can be event monitors, which means that you gotta press a button or trigger something so that when you feel palpitations, we wanna know what's going on with your rhythm. I have no idea why this model is so much better looking than this model. I will say that these monitors are equally as good. So that or that, I don't know. That's just what I found. So, okay, and then we move to the more invasive. So right heart catheterization. I'm not going to spend any time on this because Dr. Kahikas did a great job with this. But this is our gold standard for measuring pulmonary hypertension. Right, we stick that catheter in a big vein. And go in through the right side of the heart, and we measure pressures as shown here. Okay. Therapeutics. So for therapeutics, like many other things, unfortunately, in scleroderma, we don't have a lot of trials, especially randomized controlled trials, which are our favorite trials, to help us figure out which therapeutics are the best. And on top of that, you know, designing or coming up with therapies that specifically target this or that can be very complicated. So a lot of what I'm going to tell you is just based on smaller studies, people's experience. But in general, when someone has vasospasm, that spasm of the arteries, or that calcium channel blockers can be used for that. Same thing like in Raynaud's. You see people who have the vasospasm in peripherally, right? And we give calcium channel blockers for that. It's the same idea in the heart. It's the same idea with the coronary vessels. So we give calcium channel blockers for that. ACE inhibitors is a type of medication we give patients who have any kind of left ventricular systolic dysfunction. That's when the pump is not working normally. Spironolactone is also a drug we give to these patients. That's a type of diuretic. So we give these drugs for patients who have LV or RV dysfunction. Diuretics we give anytime there's swelling involved. Steroids, immunosuppressive therapy for inflammation, fibrosis, and then the pulmonary vasodilators Dr. Kahikas talked about for pulmonary hypertension. Busy slide, but this kind of puts it all together. I'm going to take it apart a little bit here. So this is really the algorithm that I kind of think about when I have patients who have scleroderma come into my clinic. So if patients come in and they don't have any symptoms, we'll perform an EKG and echo, we'll get blood tests. And if there's no abnormality, then usually we'll do annual screening and move on. If there is an abnormality, then we'll move on to other types of studies. And certainly if these are patients that are coming to a non-cardiologist, this would be a good time to refer that patient to a cardiologist. So if patients have these symptoms or there's a referral to a cardiologist, then we'll do a lot of the studies that I mentioned earlier, and we'll look for these different problems. LV dysfunction, the first question I want to know is there chest pain? If there's no chest pain, then usually I feel okay getting a stress test. And that can be many different kinds, but the stress MRI is on there. And if it's negative, then I'll treat the LV dysfunction with ACE inhibitors and diuretics. If it's positive, then a lot of times we'll go ahead and do an angiogram. And like a right heart catheterization, it's an invasive test, but we're looking at the coronary arteries of the heart. And we're looking for big coronary artery disease because even though there isn't a known connection between scleroderma and coronary artery disease is very prevalent. And obviously many patients with scleroderma can still get coronary artery disease. So we'll look for that. If there's significant coronary disease, then a lot of times we'll treat it with a stent, open up the heart artery. If there's not, we'll go down here and consider that this is probably the chest pains coming from that vasospasm or microvascular disease. And that's when we'll go ahead and we'll treat with calcium channel blockers, okay? Right RV dysfunction, I want to make sure it's not due to pulmonary hypertension. We're going to get a right heart catheterization to look at that. Pericarditis, we're going to try to treat with anti-inflammatories. A lot of times we'll start with things like ibuprofen, colchicine. If the pericarditis doesn't get better, it can get thickened and fibrosed, and that's when you can get this constriction, and you might need an MRI or a cath. And then arrhythmias, the vent monitors, and then treat with calcium channel blockers, anti-arrhythmic drugs, etc. So that's it. That's all I have, and we'll take any questions.